Okay. Yeah, I think most of our materials are going to be just in your email. And just to tee up the second item on our agenda, Senator Becker, is you and I are just going to chat a little bit about the New Mexico conference, maybe some of the highlights.
Okay.
I understand Senator Cassidy's speech was interesting.
It was very interesting. Kind of a sad way to end such a good conference, but as commented on by a couple people, but it was too bad.
Yeah, I think those things get scheduled 6 months ahead of time and had no idea of the timing.
Yeah.
Huh. Christina Holmes. See, I don't have you on video, but we do have you on audio. Christina, if you just want to unmute yourself and say hello and where you're from. Maybe I can unmute you. So Christina, you should be unmuted if you just want to introduce yourself.
Oh, wait a second. Insistent.
Okay, maybe you have a little problem with the audio there. Sue, we see your office. Do you want to say hi, Sue Stern?
Hi, how are you all?
We're good. Feel free to move your camera around so we can see your smiling face. I know you're laughing, so because we can hear that. Good to have you today. I'm just running through some other people who are calling in. I have a 206-598 number. I'm not sure if that's you, Sue, because I recognize that as a UW number.
Yeah, I think that's me. I use the phone.
Okay, great. Adam Romney, great to see that you're joining us today. Are you on video or by phone, Adam?
Dr. Scott, I don't see any audio on his end. Doesn't look like he has a mic.
Okay. Yeah, I don't see it. I just see a black screen there. So Adam, I don't know if you can hear us, but there is a call-in number too if you want to try calling in if you're having problems joining through Zoom. Brody, good to see you. Chico. Your audio is doing fine.
Great. Sorry I wasn't able to make it in person. I'm in Portland today.
Oh, well, you're probably going to be driving right by us. Great. And we have some other numbers, 206-963, if you want to unmute yourself and just tell us who you are and where you're from.
It's Cara from University of Washington, and I'm in transit, so I'm going to mute.
Okay. Cara, you want to park in the Jackson garage, and we're just across the street from where we usually are. And we also have a 206-757. You want to please tell us who you are and where you're calling in from?
That's probably me. This is Adam Romney. That's the phone line.
Oh, okay, Adam, great. Glad you're calling in. So Randy, 206-757 is Adam Romney. And I think we've got everyone. Folks here want to sign in if you're a guest. If you're new, the way we work is we do have a permanent steering group as part of the collaborative. And if there's any voting, then we do ask that if you're only a voting member, that please, if you're a member of the public, please don't vote. Because we do have some issues today that require a vote. And we do have a period of public comment at the end. We'll do introductions and comment at that time. But since it's a a little bit 5 minutes after the hour. I think we're going to get started, and maybe what we can do first is just to review the minutes from August 24th. That you should have those in your inbox. If you're here in person, you should have a copy of those. There were a couple of action items that I wanted to make sure that we followed up on. Everyone should have received the presentation from Denny on the NRTRC. This was a presentation from Alaska about using telehealth for palliative care. If you did not receive that, please email me or Priscilla and we can send it to you. And Priscilla, did we put that on the website, do you know?
But it's not on the website yet.
Do folks want that on the website? Is, these kind of presentations, are those helpful to go back to?
I think that would be helpful.
Okay, all right. So I thought it was an excellent presentation and something that we had a rich discussion on.
Sorry, this is Brody. I did not get an email with the minutes order, so just not sure if it got lost.
Okay.
Sending it to you right now.
So Priscilla's going to send it out to everyone right now. If Leslie Emmerich is on the call, she was going to send us the billing codes that she had recommended for telepalliative care. And I don't see Leslie on or obviously on my list, but we'll be sure to ping her and to get that and send it out with folks. Another action item was when we were talking about remote monitoring, and I think I had mentioned about the pilot on diabetes and using some store and forward technology. That information was passed along to Senator Becker. If there are others who want that, I can certainly make it available. It's just like a poster. There's nothing published at this time, so it's still in a pretty general version. The other thing on the minutes from last time is that we have been talking about the revised policies on MQAC from MQAC, especially related to the Interstate Compact. We did check in with Micah to see if there's any kind of progress on their policies, and he said at this point they have not, but they expect to have it next time. So we'll make sure that he gets on the agenda for next time. Otherwise, I'll just see if there's any questions about the minutes last time or suggested edits.
Dr. Scott, this is Denny. Just a couple small ones on page 3. Under training providers, number A, instead of house of collaborative training, it should say hours of collaborative training.
Okay.
And then they can be, and then it says they can be signed off for credentialing. It should probably say they can be privileged for telemedicine.
So should we say they are signed off for privileging rather than credentialing?
Right.
Okay, thank you. Okay, we'll make those changes. Any other typos or things we need to edit?
This is Sue Stern. So the only other thing is that Cameron Buck was on the phone in my absence for this, just so you know.
Yes. Okay, we'll put him as an attendee. For those of you who don't know, Cameron Buck is ER doc at the Valley Medical Center. All right, well, if there's no other suggested edits or comments, do I have a motion to approve the minutes? So moved. Okay, a second? Second. Okay, any other discussion or questions about it? Okay, so all those who are in favor for approving it, please raise your hand or say aye.
Aye.
Okay. Denny? Denny
Yes, sir.
and Ricardo?
It's the mute button.
Ricardo?
That's aye.
Okay. Any say no? You just go back and work on this? Is that a thumbs up, Ricardo? Okay, all right. Any no's?
I was muted.
Okay, thank you. Great, so we will make those edits and then post those to the website and send out the final version. So then the next thing I wanted to move on to was an update on Project Echo. And for those of you who may not be familiar, Project ECHO is a case conference model of doing telemedicine. So you basically have clinicians talking to clinicians and teaching them how to take care of complex problems. Is something we've been doing at the University of Washington, and mental health, pain, other chronic conditions. And Senator Becker and I both went down to New Mexico where Project ECHO started, and they had what's called a Meta ECHO conference. And so they had people from all over the world. They had over 650 attendees, representing over 110 hubs. And it was about a 3 or 4 day conference. A couple of things I will talk about is the ECHO Act, which was a federal law that was signed into law in 2016. And it mandated that HHS had to do an inventory of all the Project ECHOs in the United States and Canada, and to write up the evidence base for ECHO, both the clinical and the financial evidence base for how it's potentially helping the healthcare system. And then they need to eventually have recommendations to Congress in 18 months as to whether Project ECHO should be something that is paid for more easily. They are being assisted by the RAND Corporation, and while we were there, we met the lead people from the federal government that are doing this, and I had an opportunity to speak to them. So that work is underway. Other things that I learned at the conference was how ECHO is being used in other areas besides healthcare. So there are people using it for education, law enforcement, which was kind of an interesting one. We saw this really amazing video from the sheriff in Rio Riba, and he showed how there was a man who was suicidal. He was despondent from a relationship issue. He was a trucker, and he was trying to do the suicide by cop, trying to get the sheriff to shoot him. And this sheriff had participated in a Project ECHO between psychiatrists and psychologists and law enforcement, trying to teach them how to identify people who are having mental health issues and how to de-escalate. I think there's been a lot in the news about people who are having psychotic breaks and getting shot. And so that was very interesting. Apparently there is a policeman from the Seattle area who has been participating in that. So that was a new application. And then the other area I think that holds a lot of promise is it's called community health workers. In the Spanish-speaking area, they call them promontoras. These are people who are really trying to help people with change their behaviors to healthier behaviors. So not necessarily a dietitian, but really trying to get them to eat healthier, how to exercise more, and working in part of the healthcare team. So this is something that Project ECHO does really well. We had some amazing speakers, including the president of the AMA, the president of the University of New Mexico, some federal legislators, and I think the most moving people were actually patients and people who are doing Project ECHO, who really showed how to transform their life. I'm going to stop there and see what Senator Becker had to say about her time in New Mexico and some take-home points that she'd like to share with the group.
Thank you, Dr. Scott. I definitely would like to share. And first of all, I have to say thank you, Dr. Scott, for piquing my interest in the ECHO program enough that I would make a trip down to Albuquerque. That was a really rough task to do. I would have to say that conference was the best conference I've been to for a number of years. And I think it really cemented with me that all of us in the political arena need to make sure that we're looking at the side of the political area only. I'm not sure what that noise is, but what I was really impressed with was the ability to train primary care physicians, physician's assistants, nurse practitioners, ARNPs, community health workers, so that they could work within their community And the patients are best served when they can work in their, see a physician that can take care of their chronic issues locally versus having to travel to the big universities or to the big cities. So I was totally impressed with that. I was excited, and I think Leslie would be really excited to hear about the palliative care, but the diabetes and the mental health treatment. You know, this, Dr. Scott and others, was the first time that I felt myself take a deep breath and say, aha, there is hope that clinicians will be able to have a say in the direction of healthcare. And I think it's through something like this hub and the training process that goes on that actually will help this occur. I think really and truthfully, when I learned about the funding issues and looking at the University of Washington, for example, who is dependent upon grants and grants only, I would like to say that I'd like to look at some possibilities of doing something with the state of Washington to help stabilize that funding. I think that, you know, I went down there thinking I was going to learn more and more about telehealth. I did, but from a different perspective. And I think the thing that sticks out in my mind so very much is the fact that all of this, the issue that we had last year with our bill to create parity in payments, maybe what we need to do is pull in the carriers from a different perspective and have them look at what the potential for this is in saving them money in the long run. I too, Dr. Scott, was totally impressed with seeing the educational part of it, teaching the teachers, so to say. But law enforcement, I agree, that was an amazing video, and watching that man save another man's life was what this should all be about. I talked to a community health worker and talked to them about the program as it exists now, and that there may be a certification program. And to me, I think that is something that we could maybe strengthen. I always have an issue with, are we working to the highest level of the scope, or are we working outside of the scope? And maybe this is a way to look at training those non-clinical workers in a way to get them certified and give them that continuing education they need. All in all, this was the best conference I've been to for a very long time, and I thank you.
Great. Wait, can everyone hear me now?
Yes, loud and clear.
Okay, great. Thanks, Randy. We were just making sure we didn't get any feedback there. Thank you, Senator Becker, for that. I just want to see if there's any questions about this conference and Project Echo in general. Cara, I know that you're doing it for psychiatry and addictions. Any update there? Cara might be walking in. Shouldn't be parking.
Oh, there she is.
I'm unmuted now. Not really any updates except for that the psychiatry and addiction conference series PAC, we call it, which is our ECHO program in the Department of Psychiatry, is going really well. I mean, I think we've done some year one evaluations, and people are very happy. They feel like they're learning things that are important in their field of practice, and are learning things that they think they will implement and change their way of practice. So I think it's overall been, so far, a very successful program.
Thanks, Cara. One thing I wanted to announce to this group is that my colleagues at Seattle Children's have gotten a grant to do child psychiatry through Project ECHO. Just heard about that. It's a 5-year grant. So if you have primary care physicians, pediatricians who have those challenging cases and they have access issues, they can come to this teleconference and can learn how to take care of it. If you're interested, I can connect people with my colleague at Seattle Children's. So that's a great resource. I'm sorry,
Dr. Scott?
Sheila, what are you going to say? Yeah, go ahead.
Did you say that was for psychiatry or for palliative care?
Child psychiatry, Denny. Yeah, I know there's a huge need out there for child psychiatry in particular. And of course, there's always the PALS line if you want to talk to a psychiatrist directly, but sometimes it's not urgent and you just want to keep learning and hear about other people's cases. That's another great resource if you want to do this more longitudinally. Sheila, did you have a comment or a question?
Yeah, a question just about the conference, talking about the whole reimbursement piece, because that always seems to be the big elephant in the room. So did they talk about, I mean, I know you talked about HHS and having to put together some recommendations. Is part of the recommendations going to include reimbursement? Is it mostly just
I think so.
evidence-based?
Yeah, and maybe I can ask Senator Becker to expand on this, but she and I both went to a session focused on government's role in Project ECHO. There was a gentleman from Northern Ireland who spoke about how the region of Northern Ireland is supporting Project ECHO. And then Senator Rodriguez, who's the, I think she's on the House side, the House Committee Chairwoman in New Mexico. And then there was also someone from the state of Missouri. And they just basically talked how they've been working with Project ECHO to really identify the health needs and also the regions in the state where they really need it. So that was I think a helpful conversation. Senator Becker, any other follow up on that breakout session where we had the folks from Missouri and New Mexico there?
Just to mention that, there's a number of states, quite a lot of states actually, that have created or have enacted the parity payment methodology. But I think that what I would rather focus on, rather than, I know that the payment parity is the main thing, but I think that what we need to do is recognize, as I learned from this conference, that there is the potential, because of these earlier interactions with the type of training provided in ECHO, that the patient themselves will have earlier and often better outcomes, saving from a lot of emergency room treatments, etc. So I think it's a process of getting everybody to sit down and trying to find out what those points are in Washington. That's what I was speaking about. That may be a roadblock for one group or another, and then try to come to some kind of a consensus or an agreement. I do believe that Missouri has done a great job, and I've read the Mississippi portion of it. And I think other states have really set the guidelines in it. I don't know if guidelines is the right word, but they put us on the track to looking at it and saying, where is the value here? And that's what I got out of it.
Yeah. We were able to meet with the lead physician for the state of Missouri, Dr. Williams. And I think he owes us some data on the value of ECHO to the bottom line. So once we get that, we can share with folks. Any other questions or comments?
Would it be possible to get a synopsis of what those states have done so far, so we're not reinventing the wheel, but we can learn from, and I'm not asking for a report, but something brief that,
Sure.
if there's something out there,
Sure.
that would be helpful.
Yeah, New Mexico has 10 years of supporting us, and so and it's fluctuated their support as financial situations dictate. So the states I'm aware of that support ECHO are Missouri, New Mexico, Nevada, and potentially Arizona and Utah. Not a whole lot on in the eastern United States, and then Ontario, Canada has had a pretty support program in their overseas. So I'll get those. And would it be helpful to see kind of what the legislation was and the reports to the legislature, that kind of stuff?
I guess I'd like to know how it's being used.
Yeah.
And we'll always look at if they have earlier care, what's the cost savings? Because that's always what we're going to be looking at. Is cost savings down the line.
Sorry. Yeah, so cost savings, okay. and some legislation. Okay. Any other questions or comments on that before we move on? Danny, can you hear me? Yeah, okay, good. Sorry, we're just making sure we're muting and unmuting, because otherwise we get that feedback. Good. So maybe we'll move on to the next item, and that's the report to the legislature. So just a reminder that in December, this collaborative needs to submit a summary of basically what we've been talking about and what we've learned in the last year. What I did last year is I basically took Priscilla's notes and kind of summarized it into topics. And then I was kindly got some nice edits from Denny and Joelle. And I'm looking to see if there'd be other people who'd be kind enough to be an editor. I'm not asking you to be the primary writer of this, but if there's anyone between, say, November and the end of December who would be willing to at least review what I've written and correct anything that's wrong. I'd like to have at least more than one person who could serve as an editor. Brody, you can, oh, thank you. Thank you. Anyone else want to be an editor for me?
I'd be happy to.
Thank you. Thank you, Sheila. Great. So at least we have two there. And if it's okay with Adam, if there's anything legally, especially the stuff around consent, I might just highlight those areas and get your specific feedback, Adam. Is that okay?
Or look at.
Or if you're... Okay, thanks. Yeah, if you're a subject matter expert in one of these things, I might particularly say, just take a look at this. So I'll start preparing that, but I want to make sure that we have an opportunity to discuss today what are some of the things that are still unanswered or not we haven't talked about yet. Representative Schmidt, you had mentioned the parity issue. And do you want to say a little bit more about that? What your questions or concerns are around parity?
Well, I don't think we've really, at least I don't recall a time when we've talked about, is that face-to-face the same as a video conference meeting? And I'm sure there's research out there, defining that, and the outcomes there. Some of the things I know we can't control, but for the doctor's standpoint, they spend as much time with that patient over a video screen as they would have if they had a face-to-face meeting. If I go to a doctor's office, I'm going to see a receptionist, I'm going to see a nurse, most likely, prior to seeing the doctor. If I see him there's going to have to be an IT person. It's a different way of looking at it, but how do we define that?
Okay.
There has to be a value there. If there's a value there, that's a lot easier to suggest or tell the carriers.
Right.
There is value here.
Yeah. So really understanding the costs behind that and the efficiency and savings there. That's what you're looking for.
Well, that, and also is that face-to-face the same as a video?
Yeah.
I mean, I'm sure has to be some research out there to take a look at that. Hasn't there been?
I think there has been. I think the hard thing is that it depends on the specialty. So the very good evidence that psychiatry conducted as if I'm sitting right in front of you versus in front of a video screen, pretty much the same. But then you start getting into other specialties, it can be a little bit different, where especially if you might need to get a little basic physical exam, how do you get that? That's where sometimes you start getting into it can be a bit different. So as we talk about this, realize that some specialties are more conducive to it.
I get that. I'm guessing dermatology would be one.
Dermatology, yeah. I mean, the things where they're super visual and you don't need to push on them or listen to them, right? And there are peripherals that people can use as well to augment their exam.
Can I just make a couple of comments on that? So it also depends upon basically the location of the patient and the provider. And as you said, I mean, traditionally we think that dermatology is one basically, or rheumatology with telemedicine. But telemedicine in US, we are a bit new in this, but across the globe for the last 15 years, it has been done a lot. And even in US, we are getting a lot of data. There was just a recent study in assisted living facility where just one organization, I think in New York, saved like $3 million to Medicare in the assisted living facility situation, where now the doctors are able to communicate a bit more using more multimedia kind of basically. And that study suggested that Medicare can actually save $15 billion if we just are a bit more efficient using video technologies and other modes of communication between doctors. Because if you see in nursing home, most of the time we are doing remotely the things. But once the patients start getting any kind of issue, let's say start developing UTI or pneumonia, if I can see that patient, face to face remotely on a video communication, I can get a much better feel of it. And if there's other ways of communication, let's say, usually it is very inefficient. They text basically a nursing home doctor, sorry, not text, a fax. So he's in some other city or doing something else, and he will see that fax after 2 days. So if I'm getting a text in real time, and if I have the ability to see that patient in real time, and if I can just order a lab just by click of a button on the phone, and if I can prescribe medication. So there has been multiple studies, and it has been shown data in Canada and here also, that you can definitely reduce admission, and there's hard data, actually large amount of data even in US. And in the outpatient environment, I can tell you one scenario that I faced myself. So, I worked with SureScript for 16 months to get basically certification for Suboxone, the addiction medicine, and the narcotics from the phone. And then I had a practice in Federal Way of about 4 physicians. One of them come from Bellingham. So they wanted me to help them with basically Suboxone, basically remote. And most of their patients come from Longview. Yeah. So we have all the certification and licensing, and it took me 2 years to get that. But I stepped back from that because it was not very clear that the doctor sitting in Bellingham and his patient in Longview. So let's say the first encounter he needs face-to-face, and he did in their clinic in Federal Way. But the subsequent he can do remotely. So if the patient is in Longview at his home, and there's no ARNP or MA or anybody else present over there, whether that's safe to do it or not, basically what are the laws and stuff. So I actually pulled back from that. Even though we have the technology and all the certification and licensing, you can just click a button here and all the authentication done for Suboxone treatment, they can do it. But we are still not deploying it. So that's where I think the legislation will need to step in. In terms of technology, providing additional care and saving money, there is enough data, especially in assisted living facilities, especially in addiction patients. Mainly, many of us basically, are holding back because it's still a bit risky being physician and being technology providers.
That brings up another,
Just for a record, who are you?
Yeah, I'm a hospitalist with MIS. I'm Wayne's colleague. And I have basically volunteered as a health physician leader for this organization in 2013-14 when we set up EICU between Grace Harbor and here.
What's your name?
Jawad Iqbal.
Okay.
But I've been involved in this telemedicine for the last 15 years.
Okay.
that brings up another area though. If there's real savings that we could see in nursing homes there, because the patients that we take care of as a state, that's something we can just tell. That we're going to do this. That we can be a lot more proactive about, in that area. It's another road that we haven't gone down, but I can see that.
And the numbers, just in last 6 weeks. So Dr. Wortman was one of the main nursing home doctors here, basically one of our senior, Dr. Mia. So we showed that we increased the revenue by $120,000 per year in the first 4 weeks, like $12,000 per month, because state does not have to, create more reimbursement models. Already Medicare has done it. So we basically, all these patients in long-term patients in these facilities, so they can do chronic care management, they can do annual wellness visit, they can do EHA, they can do remote encounter. So there's so many ways of physicians' ability to make basically revenues. And the nursing homes don't have to actually give more money for that, or the governments don't have to give. It's just basically facilitation of the CPTs or the courses that are already available. And and it has been shown in USA in multiple states. I mean, we may be just one of them. There are thousands of them basically who are doing this. I think the speed is not there because we're still a bit scared. that which areas basically we should be pushing more and create more.
So I'm hearing nursing home, this issue of parity, we should tee up. Other things that people think would be good to talk about and report out to the legislature.
Dr. Scott, I'm wondering if we need to revisit the whole subject of teledoc issue with reimbursement models and business models, which I think was probably the biggest barrier that we ran up against. And, health systems have some of the same issues or questions with some of the models that they set up as well.
Yeah. Just to elaborate on what Denny was saying is that Teledoc is a national firm, and that's all they do. So they have a efficiency of scales that none of the health systems here are really going to have. So one thing I want to follow up with the group on next time, if it's okay, is about disaster preparedness in telemedicine. So I think Representative Schmick, at some point you had mentioned that. I am set to talk to the disaster preparedness statewide group on Wednesday. And I'll share how that goes. I think in the setting of the hurricanes this summer with Irma and Harvey, and there's already some stories emerging how telemedicine was used. In fact, Teledoc was for some of these folks. We'll see if there's anything that can come of that. Senator Becker, anything from your perspective we haven't talked about that you think we need to tee up, either next time or the time after that?
I like what we're talking about so far, but I think that what we still need to be really cognizant of, and I'm not sure if anyone's reached out to talk to the malpractice carriers to see how we can make sure we address that so everybody that's doing telemedicine is protected.
Great point. Does anyone have any contacts with the malpractice carriers?
So
actually, I do. Yeah, this is Senator Becker. I actually do have contacts there from my working time and still know a number of people up in the process, and I can make a phone call and try to get some information if others don't have the ability to do that.
That would be great, and I'm wondering, I really appreciate that. I'm wondering, Adam, if you have any contacts with the actual carriers, the insurance companies that provide the malpractice coverage, like the doctor's company and things like that. Adam, do you have any contacts?
I have contacts at Physicians Insurance. That's my main one. And then,
okay.
Yeah, I was just going to say, Dr. Scott, so I have worked with someone at the doctor's company before and could get in touch with them.
Good.
Great, thank you. Yeah, I bet you they're really interested in this because it's such an untested area, and they don't really know how to cover for it.
Most of the insurances are now providing this with the same, actually, without any additional money from us. They're covering for it. Physician insurance is one of that. We have insured many physicians through that also. So it used to be kind of a slightly unknown area, but it's becoming more and more common that they're becoming comfortable with it. Yeah. So it's not such a barrier anymore. It used to be a year and a half ago, but they're becoming more common.
Is there any evidence that by having telemedicine that a hospital's premiums can actually go down? I mean, I'm thinking of maybe a smaller hospital where they don't have a neurologist, but if a stroke patient comes in, they can do a telestroke visit. I mean, just as an example, or a psychiatrist. Would that actually lower their rates? Does anyone know that? Because if I'm an administrator of a hospital and I can save 10, 20 grand on my malpractice insurance, that would be pretty significant savings.
I think one of the savings that critical access hospitals especially they can do, and there are multiple models, Arizona has quite a few of them, that the critical access hospital now get even reimbursed for that because all of them qualify for this basically, and they do not have any of these subspecialties. So let's say if a chest pain patient come in their ER and patient may getting basically ended up staying over there, and this 2 midnight rules and all of that, they actually lose money. So if a cardiologist remotely from here, let's say, is seeing the patient, the cardiologist has more likelihood of discharging that patient after 6 hours from the emergency room. But the person, family practitioner or ER physician who's taking care in that critical access hospital, most time it will stay over there for a couple of days. Yeah. So there is good value right away that can be done, and multiple states are doing that, especially in critical access hospital setting, because they don't have any kind of subspecialty support. And they can actually charge for that as an originating site facility. And the cardiologist sitting anywhere, let's say in multi-care or Swedish or lone independent, can charge the full encounter. So the reimbursement models are already available. CPTs are already available. It's it's taking a little bit of time because I think there's multiple other fears and liability issues that doctors basically are a bit slow to catch up.
Great, thanks. What about Cara or Brody, Mark Lowe? Do you guys have any things that you think would be good to tee up for our next couple of meetings?
Mark, the disaster thing had come to my mind as well, John. I think that would be a good one, and I know our disaster committee here is also about that.
Dr. Scott, this is Denny. I wonder if this group would be interested in talking about some of the federal telehealth bills and which ones we might get our federal legislators to encourage them to support.
Yeah. Well, we can certainly educate people on what bills are out there that have been proposed. More as an FYI. Yeah.
Might be helpful also.
Ricardo, say that again.
Oh, I'm sorry. Yeah, in respect to malpractice for community health centers, FTCA is it, the Federal Tort Claims Act. So I'll be checking with them. And somebody mentioned physicians insurance. I'm sure John, since the UW, I believe, is also with physicians insurance. I'd like to hear what do they have as far as the coverage. Is that pretty much accepted by insurance as part of this practice that is done here? I'd like to hear, and then I have another follow-up item.
Yeah. I can definitely share how we've approached it at UW. It probably give me a little more time to get it all together because there's a couple of wrinkles in there. Yeah, and we'll dovetail with the training that we talked about last time. Yeah, thanks, Ricardo.
I got the message from Mark Lowe.
Yep.
He said there from Mark Lowe over at Seattle Children's that the disaster committee at Seattle Children's was also interested in how telemedicine might work if we had an actual disaster. So that's a big item.
Yeah, Mark, I don't know if you heard that what I said earlier, that I'm presenting to the Disaster Preparedness Statewide Planning Group on Wednesday. They're meeting at Swedish Cherry Hill. If you wanted to let your friends know, I'm presenting at 6. And I'll obviously summarize it to this group. Yeah.
Thank you.
And what I was saying was, I think it'd be interesting for this group to debate and take a position on the interstate licensure compact and whether Washington State should be a part of that.
Well, we are. It was signed into law.
All right, never mind.
Done and sealed. Yeah. Yeah. We're just waiting for MQAC to give us some policy on that.
John, I got a follow-up item. The other issue I wanted to mention, perhaps we can have it for the next meeting to dig a little bit further, is that on the reimbursement methodology for these type of services. I'm pretty much leaning now, my organization's team is leaning geared towards starting telemedicine, beginning with dermatology out of the White Center Central location in Seattle. And I wanted to know if there was any progress on the letter that you sent. I believe you sent a draft of the letter to the healthcare insurance before that I got it. Is there any progress on that letter?
Yeah, we will send it out. We're just trying to get the most applicable folks at each of these insurance plans. Yeah, so that's it'll go out. We just need to make sure we send it the right people.
So for all the malpractice, FTCA is going to ask us. The feds are going to ask us for sure, as well as the healthcare plans for reimbursement. One of the questions we're going to ask: what format? What is the model that they are going to be approving? is it okay just to share the general model in the report? This is what we want to be doing, how we want to be doing telemedicine. Is it okay to share that description of the model that we are adopting?
I think so. I mean, I think that's fine to share the report. Obviously, you're going to have to adapt it to your circumstance.
Okay.
So, Dr. Scott, this is Senator Becker. One thing that I think we should look at is how we might approach looking at the cost and the outcomes and compare what we are able to do by telemedicine versus the face-to-face and see, and maybe make that a 2-year project to see what those outcomes actually would be to show whether it's working or not. I think it would be wise for us to include some kind of an outcome approach.
Okay. Does anyone know of a person who's like a health services researcher who's an expert on this kind of thing? On community, like population-wide metrics. Okay, so do you have like a population health group, Wayne? Dr. Herman?
Yeah, we do. We also have a separate research arm. I mean, we do have some published studies, at least around OB care via virtual.
Yeah.
So Beth Ann Fuguson in our research department had a hand in putting that data together.
I mean, I bet you Kaiser has something like this. Chris, are you on this call?
This is Julie from Virginia Mason, and I was just going to say there's quite a few articles online that Kaiser has published.
Yeah, so I might ping Chris Cable and see if he can educate us from the Kaiser perspective, what kind of outcomes and metrics they're tracking. Great, those are really good ideas. Cara, what's going on in mental health? What are some of the issues that you think we need to talk about?
I guess, telepsychiatry has been pretty well studied, the direct patient, to patient care. So looking at the different types of models of telepsychiatry, population-based, collaborative care, all that. Back to what Senator Becker said, I think it would be really interesting to see more about outcomes and cost differences and cost savings and things. So I know it's a big world to study, and so I think it would be helpful to if we had somebody who could come in and is a health services researcher who could get the baseline, and then maybe we could come up with a couple of projects to work on across the state, looking at specific models.
Cara, I remember there was a federal issue about prescribing benzodiazepines. Is that still kind of an impediment to telepsychiatry? It's got some name to it.
The Ryan Haight Act.
The Ryan Haight Act, yeah.
Yeah.
Do you think?
I mean, it's still. I would say it's still an issue, but we do the kinds of telepsychiatry that we do is consultative, and we don't do prescribing, so it hasn't affected us directly. I think Kathleen Myers is more on top of that because she sees patients directly more often. So I haven't tracked it that closely, but she has been.
Okay. Yeah, I'm just interested to hear what are the barriers that are still out there. Sometimes there are federal laws that are restricting us. The Ryan Haight Act is a federal law that basically prohibits prescribing of benzodiazepines by telemedicine.
This is Senator Becker again. Another thing that I think that we should be thinking about is, how appropriate it is, I'm not sure, but the opioid abuse problem that we have, and how we might be able to look at that from this perspective.
Yeah, and that's something I think that we have. Cara and I have colleagues who could probably come and speak to this group very, very informatively, whether it's Dr. Talbot, who's the head of the pain medicine division, or someone like Caleb Bantagreen, who does a lot of the research on addiction. Those two people would be great. Is that kind of what you're looking for, Senator Becker?
I think so. And then the other thing that I would like to bring to your attention is last year in our budget, we created some walk-in facilities for mental health, and they're not walk-in in the true sense of a walk-in clinic, but a police officer, for example, having say a person with a paranoid schizophrenia episode that has never had any kind of criminal history can be taken to one of those walk-in or diversion centers. And I think you do something similar to this up in Seattle. They would be able to be stabilized and then evaluated whether jail was really what was needed or additional treatment. But in addition to that, we created where people with mental health issues, a lot of the folks that come into my office say they can tell when an episode is starting and their only option is the ER, and this would give them a place to actually walk in and get some help before having to go to an ER. So I think that this would really play well into telemedicine, telepsychiatry, getting it out to the people that need it.
Great. Yeah, that's a very good topic to bring up. Brody, from your perspective, what do you think we need to talk about? Anything not mentioned already?
Yeah, I don't know if it's too early to talk about this, but just as I was listening about the comparison of in-person versus virtual medicine, one of the faster growing areas are the remote devices that can be used, from the home to be able to, I guess, increase the number of data points that a doctor is looking at. We have connections with a company called TytoCare, for example, that is an FDA-approved stethoscope that can be used, at the home by a patient. And so if one of the concerns is that there may be a potential gap between, a virtual visit versus an in-person visit, what is the role of these types of diagnostic and monitoring devices that can be used to be able to bridge those gaps?
Yeah. Okay. So your question is about what they call peripherals, the e-stethoscope, e-otoscope, and yeah. And even do these devices need to be FDA approved? And yeah, that's a great point. Thanks for that. Julie at Virginia Mason, anything you wanted to talk about or learn about? Can't hear you, Julie. I don't know if you're unmuted or you're just so overwhelmed. Okay. Would you, Julie, if you want to type something or send me an email later, we can get your opinion. Anything else before we move on to the next agenda item? That's quite a bit. I think that's going to be about 3 meetings, Priscilla. Okay, well, good. So next agenda item is an announcement that Joelle Fathi, who used to be at Swedish, has stepped down from Swedish. And so the two issues are that she is now working for the Washington State Nursing Association and is really helping to inform the Nursing Association about telehealth. And in that role has asked if it would be okay to continue on the collaborative, but in this new position as being a representative for the Nursing Association. They have not been at the table. We don't have WISHA or WSMA either at the table. So that's one issue. The second issue, if we want to replace her, she has suggested her colleague Kathleen Dahman, and you should have her CV here. Kathleen said she'd be happy to serve on the collaborative. So maybe we can take those two issues up for discussion.
I don't have a problem with her being with the Nurses Association. We chose her because of her credentials and her work prior to that.
Yeah.
I don't think that's going to change much, so I don't have a problem with her continuing.
Anyone else have problems with letting Joelle continue, but just in a different hat that she's wearing? And just for the record,
Senator Becker, I don't have any problem with that, but I really like your idea of bringing WSMA on board as well, to the meetings.
Okay. You know, we do have precedent of associations being represented. So Sheila, you're representing the Health IT group. I forget the acronym.
The Washington State Health Information Management Association.
Health Information Management. And then, of course, Dr. Stern is representing the Washington State chapter of emergency physicians. So there are at least some kind of precedent there. So Senator Becker, I think one thing that we were trying to steer clear of is having lobbyists, people who are in the government relations positions at those various organizations. And I would just say, if we're going to reach out to WISMA, that we actually ask for someone who's a content expert in telehealth, whether they're an attorney or a physician. Do you agree with that?
I agree totally.
Okay. Okay. Well, great. So do we have a motion to have Joelle Fathi continue with this group, but as a representative of the Washington State Nursing Association?
So moved.
Second. Second. Okay. Okay. Thank you. Discussion?
Can I ask a question?
Yes, please.
So I'm just looking at the CV of Kathleen Damon. Is there a barrier to asking her as well? I mean, it looks like she has some telehealth experience. That she do both?
So Sue, yes. I think what we're saying is we're going to add a position, and that we would replace Joelle as the Swedish representative with Kathleen.
Okay, sorry, I misunderstood that.
Yeah, no. So it's not a one-to-one. It'll be two. We'll be picking up Kathleen in addition to Joelle. So all in favor with having Joelle continue with the collaborative?
Aye. Aye.
Aye.
Okay. No? Any no's out there? Okay. Great. I thought you unanimously passed. And then Kathleen Dahman, who is a nurse. And just to review her work experience for those who may not have it in front of you, she's manager of the telehealth clinical program for the last 2 years at Swedish. And prior to that, she was the telehealth clinical coordinator for another 2 years. She has hands-on experience as the charge nurse for the telemetry stroke unit for 3 years, where she's precepted nurses and part of the Code Blue team there, and also has served in the stroke unit. So has another 10 years at Auburn Medical Center and also in the emergency department. So looks like about 20 years of clinical experience and at least 5 years of telehealth specific experience. So I think she's very qualified, and unfortunately Joelle wasn't able to join us today, but she spoke very highly of Kathleen. So we have a motion for her to join our group as the Swedish representative.
So move.
Sure.
Oh, okay. Second? Sure. Okay, great. All in favor?
Aye.
Aye.
Any no's? Any dissents? Okay, great. Thank you. So we got those taken care of. And next, I just wanted to open up for public comment for folks who are not on the collaborative if they have any other issues, suggestions, comments. Emily, or anyone who's on the phone maybe who wanted to chime in here.
I think you came up with a really comprehensive list of topics to tackle in future meetings, and look forward to that.
Okay. You know what, Priscilla, I forgot one thing. And what I wanted to do is, I'm going to share my screen, and just so it's more of an information thing here, is that the Joint Commission released new standards, new accreditation standards for telehealth. And these are, for many of the people in this group, they're not big surprises. But so let me just go through these. Is that the first thing that Joint Commission wants is that they have a process to confirm the location of the patient in order to assign a provider in accordance with licensure requirements. Basically, you need to know where the patient is to make sure that you're not seeing them in Maine, whatever, okay? That's the first thing. The second thing is that you have an informed consent process, which includes a discussion about the patient's proposed care, treatment, and services. And this can be, as I understand, this can be part of your consent to care documents, or it can be kind of a verbal documentation, like we've said in this group. And then right here, it talks about more of the nuts and bolts of providing telehealth. So the hospital needs to inform the patient about the care, treatment, and services that they provide either directly or by contract. Something about the charges that they're going to be responsible for, and then this is key, that the provider shows their name and credentials and any kind of contact information. So these are pretty basic things, but Harborview just went through a Joint Commission visit last week, and even though this came out on Monday, they did ask us about this. So for those of you who are going to have a Joint Commission visit, know that they're already paying attention to this. So I just wanted to alert people about this.
So is that MQAC's responsibility, like provider name, provider's credentials, and contact information? Is there a standard form that this is going, and who's responsible for developing that? I'm just asking questions.
Yeah. So the Joint Commission is the body that accredits hospitals. So every single hospital in the state gets a visit from the Joint Commission, and they have different standards based on how big you are. So my understanding is this is something that each individual hospital, if they are providing any kind of telehealth services, either they're contracting it out or they're providing their services, they need to have. They're the ones who need to have their contact information listed, not MCRAC. This is not
No,
MCRAC.
I guess I'm a step ahead.
Yeah.
As this progresses, and who does that? Where does the standardization, so that patient knows if he's using his phone that who he's talking to, credentials and whatnot? Who's going to do that?
That's each individual hospital.
Typically, from my experience with Joint Commission at Virginia Mason and Group Health and at Evergreen, it's up to the organization. And typically what Joint Commission wants to see is they want to see your policies. And so you really need to have a written policy that kind of goes through. And a lot of organizations will just go through the Joint Commission chapter and kind of look at all the statements that they make and devise their policy pretty much to reflect a response to whatever Joint Commission is looking for.
Okay.
I think there's some guidelines in the law, like we came across when we were doing our multi-care a few years ago, was that the hospitals, remote hospitals, so the question was whether our subspecialists will need privileges over there or not, which is waived basically, but there's set guidelines that the consent basically, or the information regarding this physician, in their books at that hospital. So there's certain guidelines that we have to follow, and they have to basically credential this physician basically in a different way, but they have to go through that process. And also the consent in relation to the patient, whether he's in a remote facility in a hospital or whether he's at home. So let's say if I have a clinic and I'm treating a patient at home, so all this, the documents we initially captured when we enlist the patient, the new patient, so we have a consent form over there that requires basically certain points to be highlighted over there. And in terms of the hospital, two hospitals, basically, there are guidelines and consent, so you have to have that over there, otherwise you're gonna do that. But it's the responsibility of those two hospitals or the physician who's providing the remote care to have it in their files, basically that consent of the patient.
We will definitely put this link up on the website because people need to know that.
I did notice an editor's note at the very top that says as of September 14th, the Joint Commission reached out to healthcare law today to say that they will not be moving forward with their standards. Have you heard any
I'll
other
just tell
updates
you
on
what
that?
our visit was last week, is they were asking for those policies. And maybe I don't know, maybe they're not talking to each other, but I just know that after that visit, so, my administration asked me to jump on this ASAP. So I just want to pass along that.
John, those standards
Okay.
came, just recently you said, I'm sorry, this is Ricardo, those standards came when again? Those are brand new, it seems.
Last Monday, Ricardo.
Thanks. Would you send the link of that report? I appreciate it if you could. Otherwise, that'll be fine. I'll try to find it.
Yeah, it's a super long link, Ricardo, so I'll have Priscilla send that along, and also be in our minutes, and we'll put it on the website as well.
Dr. Scott?
Yes.
This is Scott Kennedy at Olympic Medical Center. A little earlier, you asked if there were advantages from a liability cost standpoint to have telecapabilities. I checked with our risk manager here. We're about a 70-bed hospital. And one thing we do think about is tele-ICU in the future. But what I'm understanding from our risk manager is that that would not necessarily provide an advantage in the cost of liability, which is based on volumes and number and types of exposures plus claim history. But it would be interesting to know if there's a model out there or if there's a pattern out there of improved liability costs because of the proven benefit of tele-ICU or other modalities like that.
Yeah, and I think, Scott, that was kind of under the category of reaching out to malpractice carriers and understanding how this either attenuates or increases one's risk. But thank you for that particular case example, and Scott, good to hear from you. Scott, I didn't know you were on the phone, so I just wanted to see if you had any other issues that this group you think should be talking about.
No, I really don't have other new issues. I like the idea of focusing on disaster and the idea of having tele teams that could come to bear, working with tertiary centers should there be a disaster in some area, and also Senator Becker's continued focus on the opioid epidemic and looking for opportunities for offering services for that around the state.
Yeah. Okay.
Thank you.
Great. Thank you. Other public comment issues or questions?
Anything you could think of, Joanne?
We covered a lot.
Don't get him started. Yeah, I think already covered a lot. I mean, I think one thing that the governments can get advantage of, because in private sector this field is exploding. Like I've never seen anything in healthcare over the last 25 years. What's happening in the US right now? It's probably the quickly improving and basically advancing field in anywhere in technology in the world right now. US healthcare. So I think you guys can ask basically the private sector also, because they have a lot of data. Non-stop, data is getting basically there. So sometime in the public sector, we don't have access to that data or don't know about it. So when we are saying that, okay, we have to provide data to the legislature, how is improving the cost, how big the cost saving is, and quality of care. The data is there. Maybe we can basically ask private sector to provide some of that data. We don't have to, we can do it retrospectively instead of prospectively, that over next 2, 3, 4 year studies. There's so much has been done already, so much evidence available that we don't have to wait for next 5 years to collect data or small pilot projects. Right. So maybe a collaboration with private sector in the US and all the big and small companies, everybody's involved in it. And with neural networks, the automation is going at a breakneck speed. The decision support system automation, since this Google made TensorFlow, it's just I've never seen anything like that in my whole career. So maybe we can take advantage of getting some data from private sector.
And just to build on that, the ATA has a bibliography of all the studies that have looked at cost effectiveness in particular. I mean, it's huge. But at least you can maybe scan it and say, this one looks like it was in JAMA or something like that. It's probably a high quality study you can look at. Great. One other thing I would like to put on in the next 6 months is as some of you may know, there's the Northwest Regional Telehealth Resource Center, NRTRC. This is a federally funded technical resource group. It used to be based out of St. Peter's Hospital in Montana, and has recently switched to the Utah Telehealth Network. And I think it'd be great to invite them to this group and just say, hey, these are the things that we offer, just beyond what we're doing here in Washington State. I'd love to invite them and maybe just get a broad overview of what the NRTRC can do for us. Of course, you know there is the annual meeting. It's typically in April, but there's a lot more that they have going on. So I'd like to just have them give us a brief overview. And I know that Denny, you and Cara are on that. You're connected with that group. Is that correct? Yeah.
That's correct.
Okay.
Yeah, I think Deb Lamarck would probably be very happy to come and join us, at least by Zoom.
Okay. Fantastic. Okay. Well, I think we had a little bit shorter agenda today, and we'll wrap up early. But I just wanted to thank everyone for coming today, and we'll be sending out the minutes and some of those resources that we talked about. And we'll see you. The next meeting is November 17th, so about 6 weeks from now. And it'll be in Seattle at Ricardo Jimenez's place in Seymour. So that's in that kind of Georgetown area for those of you who are familiar with Seattle. Parking's not as bad as Harborview or Utah, but do allow a little bit of time to get there and find parking. Ricardo, anything else you want to say about getting to your place? As I recall, it's pretty straightforward.
All of you guys.
Yes.
Okay.
1 to 3. 1 to 3, yes.
1 to 3, November 17th at Seymour in Georgetown. Great. Okay, we'll see everyone next time, and thanks to Wayne and your team here for hosting us. For those on the phone and video, you missed out on some great snacks and treats and really great hospitality as always. So thanks. We'll see you next time.
Thanks, everyone.
Bye.
Thank you.